Hi, my name is Jonathan Finoff, and I'm going to be demonstrating a live ultrasound examination of the medial elbow. I don't have any disclosures, but I do have a disclaimer. This presentation is not meant to be a comprehensive review of this topic. Our objective is to cover the core competencies as outlined in the AMSSM recommended sports ultrasound curriculum for sports medicine fellowships.
Okay, for the medial elbow, what we're going to be starting with is looking at the flexor pronator origin in long axis. So here, proximal is going to be on the left of the screen, distal is going to be on the right of the screen. So right over here is going to be the medial epicondyle. This is going to be the bony contour as we come down to the distal aspect of the humerus where the trochlea is. And right in this area is where the coronoid process is going to be. So the flexor pronator origin, the tendon is shorter than the common extensor tendon origin, but still you should be able to see a very nice fibrillar structure here. If I scan more anteriorly, there's going to be more muscle, and if I scan more posteriorly, we're going to be starting to get into the ulnar collateral ligaments. But you certainly need to make sure that you look at the entire extent of that area. You want to look for any abnormality that's suggestive of tendinopathy, which we've talked about before, looking at hypoechogenicity, loss of the fibrillar pattern, calcifications, hyperemia, all those different things that suggest that somebody has tendinopathy in the area. If I reorient my transducer a little bit into a more posteriorly directed direction, so here we are over the medial epicondyle, and I'm orienting my transducer a little bit more posteriorly, and I'm going to flex the elbow of my subject up to about 90 degrees. And right here, you can see the ulnar collateral ligament arising off of the medial epicondyle and attaching here to the sublime tubercle. So here you can see it coming across. And one of the things that you want to do is in this 90-degree elbow flexed position, you want to put them in their form in full supination, and then you want to put a valgus stress on their elbow and look for any significant joint opening, which is not happening here in this subject. Deep to the ulnar collateral ligament is going to be a small recess, a joint recess in this area. And so sometimes you can have fluid from the elbow joint accumulating in this area, and a very small amount of fluid can be normal, but a significant amount of fluid or loose body, of course, is pathologic. After I've looked at the common flexor pronator origin in long axis and the ulnar collateral ligaments, I'm going to go ahead and look at this in short axis. So here is going to be the medial epicondyle. The anterior aspect of the elbow is going to be on the left of the screen, posterior is going to be on the right of the screen, and as I glide distally, you can see that flexor pronator origin coming out. So here's tendon and here's muscle on either side. You can glide distally looking at those. I'm going to glide back up proximally here. It's the medial epicondyle. Now if I just move the transducer posterior here, and I keep it in an anatomic transverse plane, and I go just posterior on the arm and just proximal to the medial epicondyle. This is going to be triceps in this area. Right here is going to be the ulnar nerve. We're coming down, and this is going to be the medial epicondyle right there. So here's the ulnar nerve posterior to that medial epicondyle. You can see that I have them in a slightly flexed position, but not very much. Because if I flex them very much and somebody has instability in that ulnar nerve, then it'll be already dislocated potentially with their elbow flexed. So start them out in a relatively extended position. And I come down and I look the ulnar nerve, make sure it's behind the medial epicondyle, make sure there is going to be some hypoechogenicity of the ulnar nerve in this area, but make sure it's not significantly enlarged, and typically a significantly enlarged nerve is going to be greater than 7.5 millimeters squared. But really what you want to do is look for significant enlargement relative to the nerve proximal and distal to it. Now here's that medial epicondyle. Here's the olecranon over in this area. So coming down just a little bit further distal, you're going to see a little muscle right in this area, a little bit of muscle right in this area, and a hyperechoic bridge between the two. This is the arcuate ligament attaching the ulnar and the humeral heads of the flexor carpi ulnaris, and that's the entrance to the cubital tunnel. And if I go just a little bit distal, you can see how this muscle forms over the top now of your ulnar nerve, and you're in the cubital tunnel there. Now if I come back up, here's that medial epicondyle again. Here's the ulnar nerve right here. And now I'm going to look for instability. So I'm going to push very lightly on the medial aspect of the elbow, and I'm going to flex the elbow up, and I'm looking to see if that ulnar nerve dislocates over that medial epicondyle. This is the medial head of the triceps, and sometimes it can force the ulnar nerve out. And you can see in this particular model, the ulnar nerve is nice and stable. There we go. So that completes the medial elbow examination.